Hi guys, today we're going to go through our static standing observational assessment. So we've got PJ here as a model. So first of all, what we're going to do is look at the anterior view. So we're going to look at the anterior view first. So Glenn, what are we looking at with our anterior view of our static posture assessment?
I think the first thing is to try and encourage a natural standing position, first of all, because I think when you're a physio, you've got quite a lot of influence just being in the room, and you'll see people standing to attention and doing all kinds of strange things. So get them nice and relaxed, get them standing how they normally would do. And then I like to start from the top and work my way down, looking at head position. Is it tilted one way over the other? Looking at shoulder position, is one side higher than the other? Looking at any shifts that are occurring within the spine, looking at any lateral flexion and hip heights. Coming down, looking at knee position and whether the feet are pronated or supinated is always a good starting point. I'm very big on plumb lines. I sort of have an imaginary plumb line, and that really helped me out when I first started doing this kind of thing as well, because you can quite easily envisage a plumb line coming down the centre of PJ here. Does it fall through the middle of his sternum? Does it dissect his pelvis equally? Does it fall equally between his legs? And then you can quite easily see if there's any discrepancies there. Yeah. Don't be afraid to put your hands on to help you with that as well. So with PJ, I'll be looking from the front. I'll be kind of putting my hands on his shoulders. Can I feel as well as seeing any differences there? Coming down onto the pelvis, same thing, onto the iliac crest. Can I feel a difference as well as does it tally with what I'm seeing? And same all the way through. So that's what I look for initially.
And again, looking at muscle tone as well, so just general tone of the musculature as you're going down, so that you can look for any atrophy in muscles that you think may be related to the area potentially of the symptoms or pain. Cool, great. So and then we turn to the side, so we look from the side. So again, from the side, what we're looking for is, again, as Glenn was talking about, really that head position to start with. So again, plumb line through that ear, through the shoulder. Again, if Glenn, perfect. So looking at the humeral head. So again, we're hands on, humeral head, ear position, humeral head, greater trochanter, going down through the knee and then through the lateral malleolus. So we're looking to see with this plumb line whether those points are matching up, or whether there's any forwards or so anterior or posterior movements from that point. Again, as Glenn's got his hands on there, he's also getting a bit of feedback in terms of the musculature, in terms of just general positioning of that person. From the side is much better when you're looking at the spinal position in terms of that AP direction. So whether there's any extra lordosis of the lumbar spine, whether there's any kyphosis of the thoracic spine. Again, you're looking for just general feet position, but again, just head to toe, so head position, shoulder position, looking at the pelvis, knees, and then feet, and drawing that plumb line through. Anything else you look at?
It's just really important to look at the other side as well. So quite common people will be favouring just looking at one side round to the left or something like that, but you can get a very different picture when you get PJ to turn all the way around and have a look at his left side now. Sometimes you'll see that plumb line is sitting in a different way in relation to his shoulder position. That'll give you some cues on possible rotations and stuff going on in the thoracic spine as well.
So then we're going to look at PJ from the back. So again, Glenn, what were we looking for with the posture from the back?
Same thing, plumb line dissecting through the middle. Does it fall through the middle of his pelvis? Does it land equally between his feet? That's the first port of call. What I really like about the posterior view is you can really look in depth on the shoulder position, shoulder blade position. You can pop your hands on there, you can feel the angle. Does one side feel more protracted than the other? You can come onto the inferior border of the shoulder blade, and measure it from the spinous process. Does one side sit closer or further away than the other? You can have a closer look at the musculature around the lumbar spine. Is it more pronounced on one side over the other? You really get a better view of these creases, these skin creases, indicating whether one side's flexed more than the other, or one iliac crest is raised in relation to the other. Glute activation, you can have a look. Is it prominent? You could get them to even tense their glutes and stuff like that if you wanted to see what influence that may have. And again, coming down, foot position, you can get a slightly different look at the pronation, supination by taking a look at the Achilles tendon and seeing if it's bowing one way or the other, which can often collate with what you've seen from the anterior view.
Yeah, absolutely. And I think, again, from the back, you can look at shoulder blade positioning again, as Glenn was saying, muscle tone throughout. And I think that one of the other important things to remember with these static positions is that we're not making any diagnosis from these things that we're seeing, or from these potentially different positions that we are looking at. If you, to get 100 people in here without pain, and what you're going to find is that probably you're going to have 100 different positions. You're not going to have anyone standing absolutely the same, and there's not much evidence to suggest that static postures link to injury. So it doesn't mean that they're causing the injury, but it gives you a good good information in terms of what you're going to take on to the rest of the assessment, and it's just there so that you can, again, you're creating this clinical hypothesis all the time. Again, with the shoulder blades, it's been shown that winging of those shoulder blades in a static position doesn't translate into winging in a dynamic position. So when you're actually moving, a lot of people who show differences in the static position don't show that in the dynamic position. So you can't then say if someone's got poor static posture, that means that's going to influence their injury or their pain. So I think it's important to remember that when we go through these assessments, we're just looking for clues that will go forwards with us into the remainder of the assessment, and we're not diagnosing with any of these things.
Really important point there. I think I'll just reiterate that poor static posture doesn't necessarily mean they're going to have poor dynamic movement patterns. Yeah, so you could have someone with very poor posture that when you actually get them to squat or do something functional, they move really well. And you could have someone with an ideal posture, if you like, and when you get them to move, they move really poorly. Yeah, so it's just keeping that in mind. Yeah.
So with someone like PJ, let's go through. So if we turn PJ around to the front, we'll go through just some things that we might see with him. Again, we're not going to go through all the implications of that, because we're going to, in a separate video on posture, we're going to talk about the types of posture and the sorts of things you could look for, or you might be looking for in those cases that may kind of be implicated in those particular postures. But we'll just go through just kind of talking about the things that we're noticing, so that you get an idea of what we're talking about. So again, Glenn, with PJ, what are we looking at, or what are we seeing in this anterior position?
Yeah, so let's start from the top. Yeah, let's look from head down to the feet, see if anything jumps out. There's quite a few things actually. Might be worth jotting these down yourself, having a think about it yourself as we go. I would say that his head's almost slightly laterally flexed to the right, yeah, straight away. I'm also seeing this left shoulder sitting superiorly to the right. Yeah, or potentially this one's depressed. Wouldn't want to make an assumption there, but there's a difference in the height anyway. Yeah. As we come down, there appears to be a lateral shift around this kind of area. You can see that over to the left, and much higher here on this right iliac crest. Yeah, so almost a lateral flexion to the right in association with a left lateral shift, I would say. We'll get a better look at that from the posterior view, I think. I like to just, how many fingers can I slot in? Yeah, is there a difference there? As we come down to the knees.
And again, I think with PJ, you can see that his feet are slightly externally rotated, so there's a little bit of external rotation through those feet.
It's natural resting position, isn't it?
Yeah, absolutely. And I think that the left side, there's a little bit of bit more pronation. Not a lot more, I wouldn't say, but there's a little bit more. But definitely, there's that splaying of the feet out to the side into that external rotation position. One thing you can do, actually, think about it in this position, is actually straighten up the feet and see whether that makes a difference in terms of their position. So if we get PJ, if you can really straighten up those feet, okay, and then we can see, is there a change in that position? Does it change the foot position by being in that more aligned feet position? And again, you're not diagnosing, you're just seeing whether little changes in what you're doing are going to affect the pain or the position that you're finding with his posture. Okay, perfect. So what about from the side? Let's go have a look from the side. Okay, so if we look at the side, what we see in terms of a plumb line then with PJ?
Same thing again, you're going to drop it down. As Chris was saying earlier, you want to really palpate as you do this as well, because muscle bulk can be misleading with where the actual humeral head is lying. So Head position's not too bad there actually, falling quite nicely through there. I'm going to come down onto the greater trochanter. And I'd say that's sitting slightly anterior of our plumb line. And then as we come back into the lateral malleolus, that's almost falling back within the plumb line. So from that we can say that possibly PJ's slightly anterior with his pelvis position.
Okay.
Yeah?
Yeah, perfect. And then from the back, so let's have a look from the back. So again, with PJ, we're just looking at the levels. So we've said that that left side is slightly higher, so we think that that's definitely the case, that left side is slightly higher. And again, we can see through here, there's definitely more pronounced crease, skin crease on that right hand side, which suggests some lateral flexion to that right hand side. And again, then if we look down, knee creases are fairly even. And what about that Achilles, Glenn? Let's have a look at that on the left hand side. What do you reckon?
So there is a slight bow, there's a medial bow there that would implicate slight pronation on that left side. If I compare it to the right, a little bit more pronounced on the left again, so again that ties in with what we were seeing from the anterior view.
Still maybe a little bit on that right, isn't there? But it's not not as much as the left.
As much.
Quite subtle, but again, as Glenn said, there is that little bit of bow. And again, PJ is not in pain at the moment, so as we mentioned before, that I think that's important as well to remember that someone in pain is going to stand slightly differently to someone that's not in pain. And then it's going through the assessment, trying to work out, is the pain changing that person's position, or is the position a contributor towards their pain? And obviously that it's the chicken and egg, but you go through the assessment and you make a kind of a hypothesis based on the rest of your assessment as to what you think is going on. Okay, so with PJ, we've had a look at his postural assessment, and there's some little things that you might do in order to just see whether there's any symptom change when you do them, little corrections that you can make. So with PJ, Glenn, what would we maybe be doing with him just to see if it made any difference to his symptoms?
I think we'd correct some of the observations that we've picked up on already. So we're hypothesising there's a slight left lateral shift and a slight right lumbar lateral flexion component going on here. So I would start off by correcting that and seeing what influence that might have.
Okay.
So if we come across here, I'm just going to put my hands on, and I'm going to literally shift PJ to the right.
And so where are you putting your hands, and why are you putting them where you're putting them?
I've got my hands kind of on the top of the pelvis, around the top of the iliac crest. That's to stabilise beneath where I'm going to move. And then my left hand is coming round onto his thorax basically, because that's what I want to actually shift. So I'm stabilising with one hand, and then I'm shifting with the other, and I'm holding that correction in place. Hold that there for me, PJ. Then I'm just going to lift from the thorax again, and I'm just going to tilt him slightly to the left. Okay, and I'm going to take a look at that.
And again, I think that's the important thing, is that Glenn was stabilising the pelvis with one hand so that he got the movement where he wanted it. Otherwise, what could have happened is the hips could have just shifted across, and it could have been a false positive where you think you've shifted them into a good, into a more what we call neutrally aligned position, but it may not actually be that. So I think that's really important to where you put your hands as well. And again, we're remembering that we're just looking at symptom reproduction, or symptom. Does it make the symptoms worse? Does it make the symptoms better? We're not necessarily, again, going to call or basically make any diagnostic decisions with that, but we're just going to see, gives us information, and the more information we can have about the patient, the better. Yeah,
I mean, really important point. Even if their pain gets worse when you do that, it's still giving you information. Yeah, so you've influenced their condition in a certain way, so you know that there's a contributing factor by that position. Yeah, so we're not just ideally we want to see the symptoms improve, we want to see them get better, but if they do get worse, you're still getting valuable information there, and obviously you wouldn't persist with that, but it would still aid your assessment.
Absolutely. The other thing we could do, we saw a little bit of pronation on that left side, and we could put a book or something raise under the foot and just see whether that changed his position. So if we do that, so again, you could pop something underneath the foot, and you could see whether that's having an impact on their static position. Again, we're not making any assessments on leg length or anything with this sort of thing. We're just trying to see whether that changes his posture and changes his pain. You know, there's lots of different things that might do in terms of what it might offload structurally and what it might load more, but we want to just have a look and just see whether that makes any difference to his pain. Other thing you could do, so we pop back under, is correct manually. So if you think they're pronated, you could correct it manually and actually get in there. If you get under the arch with the hand and you just pull round, to check the neutral position, what you can do is come onto the head of the talus, and then if you get PJ, so PJ, if you roll your foot inwards for me as far as you can, and then you roll outwards, and what I'm doing is I'm feeling the talar head. Basically, on the talus, you've got the two bony parts on the lateral and medial aspect, and then if you roll in slowly for me and stop there. So what I'm doing is, as he rolls in, I'm checking to see that I've got the equal position of the talus, which will put this foot into a neutral position. If it's pronated, then you're going to get much more, you're going to feel much more on the medial aspect in terms of that talar head. And then if you look at the back, then you could see the Achilles again and see whether that positioning of the talus has impacted the Achilles and made it look in a better position. And once you've done that, if you get PJ to stay in that position, just say hold that position, you can come up and you can look at the rest of the posture and see whether that has an impact on that posture. Does that make sense?
Yeah, I think also you want to be getting subjective feedback from your patient or client as well. Yeah, so asking them, how does it feel when I do that? Can you rate it? Is it better or worse than the last correction than I did? And sort of in combination with the patient's feedback, then you can work out what's had the biggest impact out of those. Well, we've just done 3 corrections now. Does it feel more natural? Does it feel really unnatural? Getting that kind of feedback as you do it, really important as well.
Yeah. So that's our static assessment. We're also in another video going to go through some postural, some classic postural positions that you might find and the kind of implications behind that. But that's going to be in our postural video. So for today, that's all in terms of the static assessment.